Professor Beniamino for inviting me in this August gathering in this prestigious webinar on COVID-19. I would like to share my experience of our experiment on COVID-19 with normal saline nasal spray and gargle. The efficacy of normal saline nasal spray and gargle on SARS-CoV-2. Before going in details, I would like to discuss something about SARS-CoV-2 from the basic points. How is it entering in respiratory system? We all know through droplets, mainly through the nostril and nasal cavity is a fertile land for the COVID SARS-CoV-2. Why it is? I am coming in details.
Okay, just a moment.
Actually, for any virus, also for SARS-CoV-2, there are some obstacles. Obstacles are dead materials, unlike bacteria, keratin layer of skin, and mucous gel of nasal mucosa. Dead layer of skin. Similarly, the nasal mucous gel is the barrier for SARS-CoV-2. Thickness of mucous gel layer is around 100 micron on an average, and the diameter of SARS-CoV-2 is around 100 nanometer. That means mucous gel layer is around 1,000 times thicker than the variant.
Come vedete, questa lubrificazione delle cavità nasali orali dovute al muco, delle cavità. Please go ahead.
Now, the mucous layer is further thicker in a runny nose of children. Mucous layer, the hindrance. Then, how SARS-CoV-2 will get attached with ACE receptor? That is the problem. Just imagine a 15 centimeter floater is trying to cross a 150 meters, that is equal to a length of football ground, without any propelling system within it. It is a real hurdle for that floater to cross that water length. But when the number is high, the chance to succeed is there. Similarly, SARS-CoV-2, if they invade mucous layer, nasal mucosa, that there is hindrance of mucous gel. So, nasal vestibule is the coveted place for SARS-CoV-2. In this area, there is no mucus gel, neither the keratin layer. So if the SARS-CoV is there with some droplets, the chance of attachment is high. It is the favorable place for SARS-CoV-2, nasal vestibule. After attachment of spike protein with ACE receptor, the variant delivers RNA into the host cell. From there, replication starts. Now the question is, after replication, the formation of merely from one variant, 1 lakh variant is replicated in a single cell. Now they will come out. Actually, for their exit route, they exploit the secretory apparatus of host cell. From there, with the secretory apparatus, all those variants created inside the cell gradually comes out, and it takes nearly about 5 to 7 days to empty the cell into the nasal mucus gel.
Quello che vedete quindi è
Is contaminated with SARS-CoV-2, that is MCS. Now, within mucus gel, they means the SARS-CoV-2 floats, and with their Brownian movement, it also gets attachment with another cell residing by the side of the previously affected cell. Now, in this phase, the variant load is not that much to create symptom, to produce symptom, but it is sufficient to produce. It is number is sufficient for transmission to the society or towards the surrounding. Gradually, the replication, there is further replication and shedding. The load increases in MCS, that is the mucus gel, within the mucus gel. In that time, due to the load, the patient may be symptomatic. At the same time, transmission is going on. Now, one thing, hand may stop.
No, go ahead. I can
Okay. Why? Now the question is, why hand wash is essential? We know SARS-CoV-2 is not penetrating keratin layer of skin. So it is not invading the skin. SARS-CoV-2 do not spread through blood. SARS-CoV-2 is a surface virus on respiratory mucosa. Why to wash hands so frequently? What is the rationale behind? To prevent accidental inoculation of SARS-CoV-2 on nasal vestibule, just like in this way, you have touched the nasal vestibule with your fingers. It is nevertheless, you might touch vestibule accidentally with your fingertips. What to do next?
Allora, volevo semplicemente
If you touch vestibule accidentally with fingertip, what to do next? Along with washing of hand, you just wash the nasal vestibule with the soap. That is okay. Nasal epithelium is in elderly compared to children is actually less moist, or rather it may be called as a dry nasal mucosa.
il naso dell'adulto ha una mucosa
Here, that's why I have already told the coveted place for the SARS-CoV-2 is the vestibule, as it is devoid of nasal mucus gel. In elderly patient, whole the mucous membrane is less moist, rather dry. So it is the wide area of fertile land for SARS-CoV-2. Compared to vestibular area, it is around 8 square centimeter, and the whole nasal surface area is around 200 square centimeter. So variant attachment in elderly people is in the wider area. There is higher number of recruitment of cells for replication. So higher amount of shedding. So there is high variant load and short incubation period. Logically,
l'interesse per l'utilizzo di una
logically, in this situation with high variant load, severity and fatality, incidence of severity and fatality is also high. Another thing, that is the micro aspiration. When the SARS-CoV-2 is infesting or infecting the upper respiratory tract, it is more or less simple disease like simple cold and cough fever like thing. As long as it is restricted in the upper tract, it is harmless. Rather, it may be termed as harmless. But after invasion of lower tract, that is the alveolus, it becomes severe. And
Man mano che il virus passa dalla parte alta delle vie.
now from upper respiratory tract, the mucus contaminated with SARS-CoV virus aspirates silently and in small amount. It is called microaspiration. In a radioisotope studies, it has been shown that from nasopharynx, the radioisotope may settle in alveolus within 10 hours. So microaspiration is common phenomenon, and that similarly occurs in SARS-CoV-2.
La microaspirazione.
Now, our idea is why we should allow the nasopharyngeal MCS, that is the mucus contaminated with SARS-CoV-2. Rather, we should wash out with normal saline spray.
Perché dovremmo usare una soluzione fisiologica per debellare?
Now, after saline spray, this area should be clean. So, there is chance of microaspiration into the alveoli will be either absent or it should be minimal. So, the involvement of lung alveoli will be the minimal, severity will be minimum, fatality will be similarly minimal.
Nella sua semplicità, lo schema di scelta.
What is the dose of normal saline nasal spray and nasal spray? Actually, we have decided empirically it should be around 25 ml spray in each nostril. That means 25 plus 25. Why 25 and 25? Volume of nose, nasal cavity is around 30 plus minus 5 ml. So it is expected that saline will come out from opposite nostril if it is filled up. That's why we are using 25 ml on each nostril. And it is done 3 hourly, at least for 10 days. Now the question is why 3 hourly? As we have in our study we found that SARS-CoV-2, just like influenza virus, it is continuously shedding from the cell. I have discussed before. So frequent nasal spray is necessary.
Il protocollo che
Now, why nasal spray is effective with normal saline? It significantly washes off mucus contaminated with SARS-CoV-2 from nasopharynx. Similarly, microaspiration of mucus contaminated with SARS-CoV from nasopharynx to lung is prevented by nasal spray. It significantly decrease or prevent escalation of severity score in HSCT lung.
E quindi praticamente
From our study, we have concluded that SARS-CoV-2 is a surface virus. And from this conclusion, we can explain why children are less affected. We can explain why elderly people are more affected. I have discussed before. Similarly, we can explain microaspiration is the cause of lung involvement. It is not through the bloodstream, it is not going through the bloodstream or in the other system. It is mostly confined in the respiratory system. We can explain heterogeneity of COVID-19. That is, variable incubation period. Why? Due to the mucus gel, if it is sufficient amount or more in volume. At the same time, mucociliary action of the nasal mucosa is vibrant, then chance of production of high virion load is delayed. That's why incubation period may be delayed. Similarly, the various age group has got various types of mucus secretion and as well as mucociliary action. That's why it varies. That's why it creates some heterogeneity. That is the confusion for the most of the people. But we explain through the surface virus mucus shell. This can be explained. Variation in severity and fatality and the asymptomatic spreader. Why they are asymptomatic spreader? But actually, it is the virion load is already created for in which the transmission is sufficient, but it is not able to produce symptom. That portion it is hampering the further attachment of virion into the SE receptor and replication is restricted. That's why a patient is staying on asymptomatic stage for a longer period or ultimately it is stamped as an asymptomatic spreader.
Allora,
Explain in this if as we know it is the surface virus, now we can explain which vaccine would be more efficacious, parenteral or nasal vaccine. It has got no hematogenous spread, so convalescence plasma can be used safely. And parenteral vaccine, it produces neutralizing antibody that is mainly IgG and also IgA. But for the neutralize the spike protein of surface virus, we need surface antibody. But this parenteral vaccine produce monomeric IgA. IgA is the surface antibody to neutralize the surface antigen, that is the surface virus. But parenteral vaccine creates monomeric IgA. But in secretory neutralizing antibody, polymeric IgA is abundant. That is, it is concentration titer of polymeric IgA is more in secretory antibody, secretory neutralizing antibody. So, secretory antibody is possible to produce from local nasal vaccine. It is anticipated. Otherwise, from parenteral vaccination, the neutralizing antibody should have to cross the epithelial layer and it must have to come into the nasal mucosal gel to neutralize surface virus.
ok, questo prego.
So, we would like to advise the use of this nasal spray before the advent of nasal vaccine or the efficacy of the parenteral vaccine is sufficiently proved. It will help people. It is just like domestic treatment. Thank you.
Molto bene, thank you very much. Vedete che quest'uomo nella sua semplicità ha fatto... Ecco, posso parlare? Commento. Questo è il video dove fa vedere con una semplice pompetta, iniettando da un naso e reclinando il capo, fa uscire l'acqua dall'altro capo. Vedete questa pompetta è un normale irrigatore che però occlude bene la narice dove c'è il vestibolo e ha un effetto meccanico direttamente sulla prima sorgente di virus. Cambiando la posizione altrettanto fa uscire il muco dall'altra parte in modo che questo muco non finisca nella gola, ma nella gola ci sarà poi una successiva eventualmente irraggiamento di liquidi e in questo modo la semplice soluzione fisiologica serve a disinnescare la prima fase proliferativa del virus. il che significa certamente un'ottima prevenzione e anche e soprattutto una riduzione dei portatori sani. Quando volete farvi un tampone e volete sperare di essere negativi, se faceste questa irrigazione nei giorni precedenti, probabilmente il tampone risulterebbe negativo. Anche i famosi portatori sani o portatori guariti dal virus che però rimane nelle vie nasali. Questo avviene perché la guarigione non ha poi portato alla produzione di immunoglobuline A e quindi